everybody. My name is Karen Liberi. I am a pelvic health physical therapist, and I work at Northwest Ohio Center for Pelvic Rehabilitation and Wellness in Perrysburg, Ohio. At our particular facility, we have 3 physical therapists and 1 physical therapy assistant who are highly trained in treating pelvic floor dysfunctions. There are plenty of pelvic floor dysfunctions that are out there, but today what I wanted to discuss with you is demystifying painful sex. A little bit more about me first, though, is that I've been a physical therapist now for 22 years, and I got into the field of pelvic health 21 years ago, so very, very early on in my career. So I had the opportunity to work with urogynecologists, colorectal doctors, urologists, kind of the whole gamut of everything and anything that can go wrong between the belly button and your upper thighs. I have seen. I am a board certified women's health clinical specialist, or WCS, which is basically just saying that I'm board certified in treating pelvic health dysfunctions. The other thing, I figure I would just kind of start off a little lightheartedly with this topic of painful sex, because it is not a lighthearted topic, but just to kind of break the ice a little bit, I have some very endearing names for what I do. Many pelvic health physical therapists out there are known as vagina whisperers. And you might think, well, what in the world is she talking about? So I figure I would bring up a couple analogies of something that you might be familiar with, and then kind of carry it through to how we can help you with having painful intercourse and making that better. So if we take a look at horse whisperer, we've all heard of the horse whisperer and that story. And so the definition of it is a horse trainer who adopts a sympathetic view of the motives, needs, and desires of the horse based on modern equine psychology, right? Horse whisperer can figure out what the horse needs. Same concept, right? So for the vagina whisperer is a pelvic floor therapist who adopts a sympathetic view of the motives, needs, and desires of the vagina based on modern biopsychosocial approach to pelvic pain and how we can help you. And this will make more sense the further I go along into this webinar. Again, just another little side note for those of you who watch the show of My Cat from Hell. There's the cat whisperer, and I thought that there was a very unique way and aspect that they kind of describe the cat whisperer and how we can kind of parlay that into what we do with pelvic health therapy, where the cat whisperer is a person who can improve a cat's relationship with its human caretaker through understanding the cat, building the cat's confidence, then training suitable responses from the cat that are in harmony with the day-to-day activities in a human being's home. Really, that's kind of what we're doing for the vagina when it comes to being able to have sex again, especially for one who has not been able to have sex for a long period of time and have really kind of lost the confidence, and there's that fear of having sex again. So if we kind of parlay that definition here, vagina whisperer is a person who can improve the vagina's relationship with its human caretaker through understanding the vagina and what is going on with it, building the vagina's confidence, then training suitable responses of the vagina that are in harmony with day-to-day activities, such as being able to resume intercourse. So that is like a little intro to what we're going to be discussing today to be able to help you out with that. So dyspareunia is just a fancy name for painful sex. Okay, and whenever women come in to see us who have painful sex, some of the very first questions that I'm going to ask is it painful like with initial penetration? Is it painful with deep penetration? Does the whole thing hurt? Because all of your answers to those questions are going to really help me to determine what the next steps of my evaluation are and helping you figure out what's the best way to move forward with decreasing this pain. So why the need? Like, why the need for, you know, even coming to somebody to address this pain with sex? I would say more often than not, OBGYNs who you first will probably bring this topic up to of painful sex, especially if you're in the menopause years, the automatic go-to is going to be estrogen deficiency. Because with estrogen deficiency, there is a decrease in lubrication, there's a thinning of the tissue, which then creates more friction, and then you have pain with sex. And when we reach the menopausal stages, there is decreased estrogen, which kind of makes sense that that's kind of the direction that physicians go with this. Now, if we kind of take a look at this graph, we can see in the pink is that superficial or entrance pain with sex, and in the light blue is atrophy, just kind of showing the tissue and how the tissue might be affecting that. And we can see that, you know, more than 4 years after menopause, even though the atrophy and the thinning of the tissue is much higher, that superficial dyspareunia is still pretty low. So, so we can't make a direct correlation of lower estrogen and tissue deficiencies with, you know, why you might be experiencing pain. In terms of well, is this even prevalent out there? Like really, like how many people are having pain with sex, and what are the differences? So the National Survey of Sexual Health and Behavior did a study which showed that those who are ages 44 to 59, 88% of men are still sexually active, while 72% of women are still sexually active. And amount of times of having sex per month, for men it was 7 times per month, and for women it was 6.5 times per month. Okay, now if we fast forward with time and we're looking at ages 57 to 72, men are still relatively sexually active at 72%, where women, there's definitely a discrepancy there, where women are only having, only 45% of women are having sex. But still the amount of sex that people are having is around the same, you know, around 4 times per month for both men and women. Now, vaginal atrophy surrounding menopause can certainly cause 58% of women to avoid intimacy altogether. But with women, like, it's not, you know, just about the structure and the tissue, you know, it's also about, you know, the emotional connection and all of that as well. And so some studies have shown that 64% of women who have had vaginal atrophy have had a decrease in libido, and 64% had pain with sex. So, and I'm talking a lot right now, I understand that, about menopausal symptoms, but I certainly see women who have pain with sex, you know, from teenage years, you know, all the way into women who are into their 80s and 90s. So this is just an aspect that I'm bringing up now, but I'm going to talk about some other things in a little while. So if we think about, you know, the tissue, and if the tissue is having issues, then why physical therapy, which is a great question. And so there are definitely studies that have looked at why is there still pain with sex after menopause, with the initial hypothesis being that it's all related to atrophy of the tissue, and that's why. But that's not what they found. What they did find is that even though, yes, estrogen declines and is you know, a contributor to pain with sex, it is likely not the only reason why you are having pain with sex. And a lot of the pain science that's out there right now, you know, is talking about it not just being like structural tissue reasons, but there's lots of other multifactorial reasons for there still being pain with sex. So what we're trying to do now in this day and age is now that we're understanding a little bit more with pain science, is to reconceptualize why people have sex, you know, after menopause right now and are having pain with that. So we're thinking that it's really a function of the biological as well as psychological fear of sex, because now it hurts, and interpersonal factors, you know, that are really contributing to the pain, and not just solely estrogen. So with the meeting of the minds that are out there and just trying to really be able to help women who are experiencing these troubles, we have found that there may not be one thing creating your pain. having that nice team approach is certainly going to be important, meaning not only having a doctor who is on board, in case, medications are needed, or Mona Lisa Touch, to help to improve just that vascularization, recollagenation of the muscle tissue to help there be less friction and less pain. They're a piece of it. The other piece of it can be a psychology piece of it. If there's just troubles within the relationship surrounding the pain with sex and inability to have sex, as well as, seeing a physical therapist that can try to help to put all of the pieces together so that you will understand why you are having the pain that you are having, make sense of it, and then be able to come up with strategies to help to make it better. So just to break it down a little bit further, for the biopsychosocial approach, bio is biology, meaning like, what is your actual tissue like? So is there atrophy? Is there tension in through the muscles that's creating some of that pain? And then for some of our patients, again, not necessarily menopausal, maybe it's postpartum patients who've had an episiotomy, or who have had tearing, or those who've had a hysterectomy or C-section, or, scar tissues in and of themselves can also be like a biological contributing factor to some of the pain that you are experiencing. The psychology piece of this is, what is in your past history? Have you always had pain with sex? Did you have a great sex life and then started to not have such a great sex life once you reached a certain point? Is there a history of trauma? So there's many different factors that go into the experience of pain. And then the other piece that I want to know too is your perception of getting better. Do you think that you are going to be helped with physical therapy? Because I can usually tell visit one based off of how somebody's presenting with me and their outlook on their outcome is of how quickly we're going to be able to get somebody through from point A to point B, and those that might just need a little bit more help with that. And a lot of it does have to do with just their outlook of getting better. And then from the social piece is what is the relationship like with your partner? What are your expectations of your relationship? I certainly have some patients coming in that, that them and their partner are just absolutely fine with just it's okay that we're not having sex anymore. And others that's not necessarily the case. They really want to be able to have that be part of their relationship. And so at that point in time, I will have counselors that I can refer patients to. So it's really a nice team approach that we help to orchestrate and organize within physical therapy to be able to help out with that. So some insights into physical therapy, if you decided to come in to get therapy, is I want to know, when does your pain occur? Does it hurt right with initial penetration and then it's fine? Does it hurt only with deep penetration? Or what position are you in that it hurts? Because all of that tells me really good information about where the pain could be coming from. I also want to know, when did the pain start? Again, ever since you were a teenager, did you have trouble putting in tampons? That would tell me something different than somebody who's always had a good sex life and then started to have pain with sex. So, some of these questions give me lots of really good information so that during my evaluation, I can be more specific with what I'm looking for. Is there tightness that you or your partner notices? And then certainly your abdominal, vaginal surgeries, childbirth history, all of that can play into just your individual history and trying to put all the pieces of the puzzle together to figure out why you're experiencing what you're experiencing. So this is not an exhaustive list, but I just want to throw these out there for some reasons for some of the superficial or that entry pain with sex. Obviously, if there's a vaginal infection, that could be painful. So if you've already had that ruled out by your doctor, then we can kind of check that off the list. Many times, women can go in with superficial pain and you might get treated for infections, but you may really not have had infections, or you have somebody who has recurrent infections, and then we'd have to wonder, well, why is that happening? And again, it just gives me more information of kind of how I would want to approach treating you. Atrophy, we already talked about. The decreased estrogen can certainly cause pain with initial penetration. Poor lubrication, also usually a sign of decreased estrogen. And then sometimes it's just like the foreplay. If there's not enough foreplay ahead of time and there's decrease of your own lubrication, then that can contribute to pain with initial penetration. For some of my younger gals that are coming in, you know, sometimes hymenal tightness can be a reason for some of the pain. And so we can certainly check that out and see if that could be a contributing factor to the pain that you are experiencing. There can be other things that are happening, like not inside the vagina, but on the outside area, which is called your vulvar area. So if you just kind of separate the labia, and then that kind of exposes your vulvar region. Sometimes if there's redness and irritation right at the vulvar area, that would cause pain with initial penetration. But then you may also be experiencing pain at other times, such as when wearing tight clothes, or like if you're sitting for a period of time, you know, so I would want to explore that further if I kind of notice some pain at that vestibule opening. And then another component could be if there's irritation just even surrounding the urethra, because the urethra is just that tube coming from your bladder to outside our body that sits like just towards the front part of the vagina. So at the top part of the vagina is where the urethra sits. So sometimes there can be irritation just at the urethra, and maybe that's what's creating some of your problems. So again, just kind of want to look at the whole picture of what can be contributing to your pain. Some other pieces might be something that's called vaginismus, which is like basically tightening of those vaginal muscles that don't allow for penetration. So there can be some people that can have sex, but it hurts. And there's other people who just cannot have sex because they are unable to have penetration. And that's vaginismus. And I would treat that differently, you know, than somebody who's coming in with some of these other issues. Excessive penis size. I've certainly had some patients who are like super tiny and they have husbands, you know, that are bigger. And so we just have to like structurally kind of work on helping to relax the muscles to be able to help that work. Cancer. So some of our cancer patients who've had surgical or who've had radiation, there's different things that we can do once the tissue is healed to be able to help with that superficial dyspareunia. Any vaginal scarring that may have occurred, and certainly just tension of the pelvic floor could be other reasons. For those patients that come in and say, you know what, you know, initial penetration is fine. It's just I cannot stand like the deep penetration. So there's different reasons for that. So whenever I think deep penetration, I'm thinking, okay, depth of the vaginal canal, what's at that area, and what could be causing that pain. And so certainly if there's a scar, you know, after a hysterectomy deep in that pelvic floor, that could cause pain. If there are some people who are experiencing prolapse and there's like a dropping of the organs into that vaginal canal, and there's pressure like right at those organs, sometimes that can cause pain. For those who do have a history of fibroids or like enlarged ovaries where there's just more things taking up space in that vaginal canal and in through that lower abdomen, that can cause some pain as well. For those with a history of irritable bowel syndrome, if we think about that, you know, just with the anatomy of where the bowel is in relation to the vagina, and then also some of the irritation and inflammation that might be going along with IBS, maybe that is a reason for some of the pain with deeper penetration. Those with a history of endometriosis, sometimes, or even like scar tissue from a C-section scar as well. If there's decreased mobility in through that lower abdomen, it's going to hurt with deeper penetration, because with deeper penetration, your anatomy kind of needs to move up and out of the way and be very forgiving. But if we have scar tissue in through that abdominal area, endometriosis, scarring down, like not a lot of mobility, then it's going to be like hitting a brick wall, for lack of a better term right now. That's going to hurt, you know. So I would want to take a look at all of those aspects to figure out the best plan of care for you. And then certainly pelvic floor muscle tension can play a role with that. So given the history and then understanding, you know, all that you have been through to get you through my door and sitting in my chair to have this discussion, we can come up with a game plan based off of what we find and what makes sense. So I just wanted to give you little snippets of what to expect. You know, if some of these things that I've already stated, you're just like, yeah, that's kind of me. What would you do for that? So I'm just going to go over a little overview of that. So the first one would be scar tissue release. And again, like if you've had a C-section scar, or if you've had abdominal surgeries, or if you've had a history of endometriosis, we're going to want to do just some scar tissue mobility, some scar tissue release, just to give a little bit more freedom of movement in through that area, so it does not hurt as much with deep penetration. And usually what we notice too is, like, as soon as we start to do some scar tissue mobility, we always want to have our patients kind of like check to see if that's been helpful. And there's lots of different aspects of how we would have you do that for home. Sometimes what we'll do is we'll work with vaginal dilators with something called biofeedback for pelvic floor relaxation. And vaginal dilators are not what the name indicates them to be. So it's not that we're trying to dilate or make the vagina bigger, you know, to allow for decreased pain with sex. They're just a tool that we're using to basically, I call it just vaginal mapping, where we're just trying to like identify, like, where are you inside the vaginal canal? Are you in the first layer, middle layer, deep layer? Where does it hurt? So your perception may be that everything hurts down there, but when we actually start, you know, with working with the dilators, and you can understand like where your tension levels are and what's creating your pain, we might kind of narrow it down to like one specific, you know, area, and we can work on relaxation of the pelvic floor with movement. You know, let's say somebody has vaginismus and like nothing's getting in, like we can start with like an extra small dilator and have you hooked up to a computer where you can see where your muscles are really tight, and then we can work on relaxation breathing, allowing for those muscles to relax, and then you would notice that there's decreased pain. You're allowed to insert further, you know, and we can kind of progress from there. And once there's low to no pain with a particular size dilator, then we can go up to the next size dilator. Again, just trying to like retrain the brain to say that this is not an area of threat. You do not need to protect me. You know, it's going to be okay. And so there is certainly some patients coming through with pain with sex that this is a very appropriate type of therapy to use. Vibration can be another piece, especially for those patients who have had like episiotomies or just tearing with childbirth, and there's just some scar tissue that is particularly painful. Sometimes vibration can be a really nice tool for them to try to help out with improved scar tissue mobility, to improve the distensibility of that scar so that it stretches a little bit more, so that there's not so much of a pain with initial stretch to that opening area. And also vibration from a neurological perspective is very quieting, you know, so sometimes for those muscles that are really tight, the use of vibration can help to relax those, and then just your recognition of, okay, that's tight, this is relaxed, and trying to work towards relaxation will be super helpful. My goal as a physical therapist is to educate you on what is happening so that you understand it within your body, and then have some strategies, you know, to work on your own. So I am just helping to identify, helping to get you on the right track. And we usually have like really good success in a short period of time, like once we can really identify what's happening with you. Breathing is a very good thing for relaxation, and many times we start with this when you're very first coming into therapy, again, just for that recognition of that is a tight pelvic floor, and then this is a relaxed pelvic floor. So the way that our body works is we have our respiratory diaphragm, you know, underneath our ribs. I am going to stand up a little bit if you can see me. And then we have our pelvic diaphragm here. So as we take a breath in, the diaphragm drops to allow air into our lungs, and then the pelvic floor also drops. And then as we breathe out, everything comes back up. So we do teach a lot of like belly breathing, just to allow for that pelvic floor to physiologically kind of drop and relax on its own, so that you can feel that happening. So before I even ever do any internal assessment with you, I teach relaxation breathing, so that when you do clench up, if you do clench up, we have a strategy right away that you can really start to like relax those muscles. And generally, decreased tension equals decreased pain, and then you can kind of start to see how physical therapy can help. And then manual therapy for just adhesions from pelvic infections or surgery. So like any type of like manual therapy work that we need to do just to allow your muscles to function the way that they're supposed to function. You know, we work on that too. And then once your muscles are actually contracting and relaxing and functioning the way they need to, we take it like right into to functional use with everyday tasks, and then also obviously like carrying this over into decreasing pain with intercourse. And sometimes we teach, actually a lot of times we teach positions for sex based off of where you have been experiencing pain, so that you're allowed, you know, some successes as we're very first getting started, and kind of going from there. Some important concepts that I want you to take away from this webinar is that we want to really try to treat all of the sources of pain and dysfunction, and we basically are trying to turn down the pain dial. So, you know, so if you're really kind of like anxious about, you know, pressure or tension or touch, you know, to the vaginal or vulvar area, you know, we want to kind of give some strategies to kind of take some of that stress away. We want to introduce like, you know, gentle touch, and then allow that to feel okay, you know, just so that we're just trying to decrease any of the inputs from that biopsychosocial approach to that overall pain experience. We're trying to really turn down that pain. So physical therapy will basically focus on pain education, manual therapy, pain management strategies, and then certainly working with your physician if there needs to be any like pharmacological approach to this. We certainly want to work with them, and then also referring to counselors as needed as well. So basically we're just trying to like down-regulate this up-regulated system because of that just anticipation of pain with sex, and we want to try to work on ways where you just know that you're going to be okay, and we give you strategies to do that. So the takeaway perspective here is, even if you know nothing about the reason for your pain and why you are experiencing it, with just the knowledge of what you've learned today during this webinar, I'm hoping that you can have some confidence that you have some really great resources in the area to help you out in Perrysburg, Ohio. But also I am very familiar, I'm part of a global health alliance, you know, where I can certainly, if you're listening from elsewhere, I can help find you a therapist, a doctor, a counselor, you know, to be able to really work on this and get the help that you need. So if there's any questions specifically for me, I have some contact information here. And then I also am doing some telehealth visits as well through the Maven app. So if you were to download the Maven app, you can get on there, and you can probably pause the webinar if you wanted to, just to get this information. So if you wanted to do like a consult with me, I am very happy to do that as well. Okay, hope that this was helpful. Take care.